Good afternoon, all. I, Dr. Santosh Shirol from Medical Affairs team of Hematology at Takeda, would like to welcome you all for today's scientific webinar on the topic of inhibitor management with Feiba by Dr. Jesse Vendega and Dr. Joseph John. As a constant endeavor to facilitate scientific discussion on the most up-to-date data in hemophilia and allied bleeding disorders, we at Takeda have initiated a series of webinars to improve our knowledge and awareness about hemophilia management. We would like to begin today's proceedings by extending our best wishes to all the COVID warriors. Before we move on to the session, I would like to briefly introduce our speakers for the session, that is Dr. Jesse Windega and Dr. Joseph John. So Dr. Jesse is an internationally reputed personality and a thought leader in the sphere of hemophilia and allied bleeding disorders. He is the professor and head of Department of Institute of Hematology and Transfusion Medicine at Warsaw Institute, Poland. He has more than 300 publications in reputed journals, author and scientific editor of 5 medical books and 50 chapters in 14 medical books. He has also been active in various clinical trials ranging from phase 1 to phase 4 in hemophilia and bleeding disorders. He is an active executive member of IHAD and WFH steering committee member and also a co-author of WFH Guidelines 2020, which is considered as one of the gold standard guidelines and recommendations for the hemophilia management. Now I would like to introduce the speaker and moderator for the day for the webinar, Dr. Joseph John. He is currently a professor in the Department of Clinical Hematology and Bone Marrow Stem Cell Transplantations in Christian Medical College, Ludhiana. He is a subject matter expert and a pioneering name in the field of hematology, a recipient of numerous prestigious awards. He is passionate towards research and clinical trials. He has been an eminent author of a book on stem cell transplantation and has numerous publications in various reputed journals. So without for much further delay, I would like to now invite Dr. Joseph John to decipher an overview of hemophilia inhibitor management in Indian scenario and current challenges to initiate the proceedings for the today's session. So over to you, Dr. Joseph John, sir.
Thank you, Dr. Santosh. And it is indeed a pleasure to have Dr. Jazzy with us and an opportunity to discuss with the Indian counterparts here on inhibitor management. And this is a neglected field, I would say, over a period of time. And I will be elaborating on some of the uh, issues which is regarding related to inhibitor status in India. It is not a very long presentation. It is only a short presentation on this. I'm trying to find my presentation. I'm not able to get it. Let me just see the screen, the application window. I am not able to see the screen. So are you able to get the screen now? Are you able to get the screen, Santosh?
Not yet. Not yet.
Sorry. So can you do that for me
Yeah,
from
shall
there?
we?
I'm not able to.
Sure, we
Some
shall.
glitches
Can I
happen.
ask
So let
Nitin
me try
to?
last once more. I got it. I've got it now. It was a bit of a hitch there. Okay. So I'll be talking about a few of the situations in India to give you an overview of uh, the inhibitor management in India. That's a disclaimer, and that's a conflict of interest slide which we have to present. So I will be taking some excerpts from the annual global survey, which is the current the survey report which is available across the world. India houses almost the maximum number of hemophilia patients in the world. But please understand that this is only about 15% of the expected patients in the world. So we understand that there is a huge gap in terms of diagnosis of hemophilia. About 80% of the patients, whether mild or moderate, are probably getting missed in making the right diagnosis. And hemophilia B is only about 1/6 almost of that only. When it comes to inhibitor status in India, you look at it and you'll realize that there is about 769 patients of inhibitors positive on a comparison of 17,000 hemophilia A patients. Whereas hemophilia B is much less. So please understand that The percentage of hemophilia development in A is about 20-30%, whereas in hemophilia B is about 5%. Considering that hemophilia B is only one-fifth of hemophilia A, the inhibitor presence of hemophilia B is only 1 is to 25 to 30 times. So that's the ratio which you are saying about 6 times is hemophilia A is more common with inhibitors than inhibitor B. Plus, by the global statistics, there are only 4.3% of the patients with hemophilia A is having inhibitors. So that's some of the important aspects which I would like to bring it to your notice. This is one of the slides which will show you about the inhibitor status across various regions in the country based on some of the studies which have been done. The Western India is about 8%, 4 to 8%. The Tamil Nadu or the southern India is more of inhibitors. Now, this could be most likely because of improved investigation facility in the southern part of the country. Hemophilia actually developed, the hematology actually developed more in the southern India as compared to the northern India. That's one of the possible reasons for that. The second reason is that the exposure of factors in southern India has been much better than in the northern India, where northern India, most of the patients probably succumbed or never reached the doctors uh, for a particular, I mean, the real diagnosis and the exposures. When we look at some of the publications in India, this is a PubMed search which I had done in terms of looking at hemophilia inhibitors publications in the last many years and looking at the number of inhibitors present over the years. If you look at it, over the last few years, the number of inhibitors reported is higher. So that's a percentage of inhibitors reported in various studies. But that is not a reflection, probably not a true reflection. That is because there is a lot of gap existing in making a diagnosis. That's a glimpse of all the references which we have looked at, or 12 good publications on inhibitors. And so there is a huge gap in with regard to looking at the amount of inhibitors we have. So that is the 12 studies which I said, which is evaluable for hemophilia and showing the various inhibitors in various years, which is so. And inhibitor positivity in various zones, if you do a subgroup analysis, we just looked at it from the publications, where are the inhibitors present based on the reports which we have got. Southern India has more of 90% uh, patients are having fat inhibitors positivity as opposed to east and other areas in the country. So, as I said, the various reasons I have mentioned earlier, and there exists a fear among the patients on the possibility of developing inhibitors if they go for prophylaxis therapy. That is something which we need to address in the country of for ameliorating that fear is very important by the doctors. And the second is improving the capacity of managing inhibitor patients in each of these countries, each of these areas. So we need to develop nurse coordinators, physiotherapists, and of course hematologists or physicians in medicine or in pediatric specialties who can manage inhibitors. And now, 10 years ago or 15 years ago, talking about prophylaxis was a taboo in the country because the question was, how would you consider prophylaxis when there is no factor for even on demand? Today, prophylaxis is a household word. In most of the meetings, we are talking about prophylaxis, and it is low dose prophylaxis, at least, is coming into being. And many patients are availing this facility now as low dose prophylaxis, especially in children. But there exists a fear. Now, please, we will, Dr. Vinziga will be elaborating it further. When we give about 7 to 8 months of therapy of ITI, there is a 70 to 80% chance that patient can be cured of inhibitors and then subsequently put on prophylaxis. So the availability of factors, many pharmaceutical industry has grown so much in the last many years. There are many non-factor concentrates, non-factor compounds available to manage this. So there is a lot of hope now in the country where we can address these issues which was quite common in the West about 5 to 10 or 15 years ago. And that is, we are catching up about 10 years gap. But I think we are there, and the gap is reducing. And the World Federation of Hemophilia has mandated to actually reach out to the countries which have lesser access to these factors. That's a good news with which I would like to stop this now, giving an overview of what is in India with regarding to inhibitors. And I would like Dr. Jersey Winziga to continue the talk and the potential strategies for the Indian patients. These are some of the strategies we were thinking of which could help in the Indian patients. This early low dose prophylaxis, probably von Willebrand containing plasma derived factors up to first exposure days based on the CPET study, regular monitoring, avoiding the exposure at very early age, and avoiding the intense first exposure with regarding to during an infection or during a vaccination process, unless it is really warranted and given IM. So these are some of the precautions we can do to prevent at one side, and one side, if they develop, we can address that more effectively. I would hand over the mic to Dr. Jersey Winziga now, who will be elaborating upon various methods by which we can uh, manage inhibitors uh, effectively, especially using fiber.
Thank you very much, Dr. John. Thank you very much for invitation and very kind introduction. And now I will open my presentation and start my presentation. I hope you can see my presentation. Could you confirm that everything is fine?
Yes, yes,
Okay,
yes.
thank you very much. Okay, so this is my topic, inhibitor management with Feiba. Of course, I will focus on Feiba, but of course, I will also touch upon and discuss various aspects of management of our patient with inhibitors. This is my disclaimer and my disclosures. And let me start with definitions. So, of course, we all know that inhibitor is polyclonal high affinity antibody that specifically neutralizes the procoagulant activity of the relevant clotting factor, which is factor 8 in hemophilia A and factor 9 in hemophilia B. I will focus mostly on hemophilia A during my presentation. We may distinguish three types of inhibitors. So-called low titer inhibitors, if titer never exceeds 5 Bethesda unit per milliliter. So this is there is no anamnestic response in patients who are low responders, other words, with low titer inhibitors. Then we have high titer inhibitors, and in patients who are high responders, the production of antibodies is higher, and therefore the titer may exceed 5 Bethesda unit per milliliter. And then the third type of inhibitors are transient inhibitors. Transient inhibitors are defined as inhibitors that may disappear spontaneously. Normally, they disappear within more or less a couple of months, like 6 months from the occurrence, and we do not observe anamnestic response after re-exposure to the deficient clotting factor. Of course, inhibitors are definitely the most challenging adverse event associated with hemophilia treatment. You see here the consequences of the presence of inhibitor. So the inhibitor complicates treatment because bleeding no longer responds to standard replacement therapy with factor 8 or factor 9 in hemophilia B. Of course, makes hemostasis more difficult to achieve, makes surgery definitely more hazardous, can make prophylaxis not feasible. In hemophilia B may lead also to anaphylaxis, also increases the cost of treatment, and also increases, unfortunately, death rate as compared with patients without inhibitors. What are the treatment strategies for our patient with inhibitors? We have, in fact, two objectives in patient with inhibitors. The first, of course, is to management. The best would be to prevent them, but in case of bleeding problems, we have to control them. We have to stop them with adequate therapy, of course. We may say that the primary goal or overall goal in patient with inhibitors is to eradicate inhibitor. Fortunately, it can be done, but unfortunately, only in about 70% of all patients who are put on ITI, immune tolerance induction. What does it mean, immune tolerance induction? This is a very specific procedure that refers to the regular, frequent, prolonged exposure to clotting factor. And through this procedure, we may eliminate inhibitor through the various very complex and complicated mechanisms, which I'm not going to discuss this afternoon. Of course, once the patient eliminated inhibitor, we may put the patient on long-term prophylaxis with deficient clotting factor. So this is definitely the best scenario for our patient with inhibitors. Unfortunately, ITI is unsuccessful in about 30% of patients who are put on this regimen. What hemostatic agents are used in patients with inhibitors? So we have 3 hemostatic agents, in fact. For more than 40 years, we have used Feiba. Feiba, which is called bypassing agent, and it is a multi-factor activated prothrombin complex concentrate that can be used on demand, I mean, to treat bleeds when they simply develop. Can be used also in the perioperative period. So we use Feiba also for surgical prophylaxis, and also we can use for long-term prophylaxis. So on-demand surgery and long-term prophylaxis. Novo 7 is also a bypassing agent. This is a recombinant factor 7A, and this drug is indicated for patients with inhibitors to treat our patients on demand. So this drug is used when the patient develops bleeding problems. And finally, monoclonal antibody, emicizumab, of course, a new drug. It emerged over the last 2 patient with hemophilia A with and without inhibitors. But what I would like to stress, this drug is only for prophylaxis, for long-term prophylaxis. This compound can be used for treatment of bleeding problems or for perioperative period. It is used only for long-term prophylaxis. Here you can see just one slide on the composition of Feiba. As you see here, Feiba contains multiple components that, of course, are involved in the coagulation cascade. So you see on the left-hand side in the table zymogens, procoagulant enzymes, also cofactors, inhibitors, also contains phospholipids. In vitro experiments carried out over the last years show that although factor 2 and factor 10A complex is the key constituent of Feiba, so we believe that those 2 proteins are the most important for action of Feiba. Nevertheless, other components play also a very important role in this integral action of mode of action of Feiba. Therefore, this unique composition accounts for success of Feiba in management of our patient with inhibitors. On this slide, you see the comparison of recombinant factor 7A and APcc, as both drugs are used to treat bleeding episodes in our patient with inhibitors. So you see there are some advantages and disadvantages for both compounds. Half-life of R7A is much shorter as compared with APcc, about 2-3 hours versus 8 to 12 hours. So the longer half-life of APcc can be, of course, an advantage in some situations, in some clinical settings. The infusion volume is bigger for APcc as compared for R7A, so we have to spend more time when we infuse the drug intravenously. The dose and frequency of doses, of course, stems from the half-life and other pharmacokinetic parameters, so you see huge differences. Novo 7 is very often given very frequently, every 2-3 hours, while Feiba can be, but it doesn't mean that you can manage all bleeding problems with one drug. No, if you treat your patient with inhibitors, you may expect that in some patients one drug is better than the second one. Of course, in some patients both drugs are very efficacious. Therefore, when you treat your patient, you should have access to both bypassing. I mean, in fact, long-term prophylaxis, I mean, only Feiba is really good. Novo 7 has been tried in clinical trials. Nevertheless, long-term prophylaxis is not an official indication for R7A. So how do we bleed patients who experience bleeding problems? So how we treat our patients on demand? Here I present on this slide, in my opinion, very elegant, very nice algorithm how we should approach patient with hemophilia complicated by inhibitor when the patient develops a bleeding problem. In fact, our decision is based on 3 pillars: severity of bleeding, current inhibitor titer, and whether the patient is low or high responder. Because we should keep in mind that patient who is high responder exposed to the efficient clotting factor for months or years, in this patient, current inhibitor titer may be very low. So in patients whose current inhibitor titer is high, we have to choose between bypassing agents, Feiba or R7A. In those patients who are low responders with low inhibitor titer, normally we start with high dose of factor 8 because we believe that this is the optimal treatment for our patients who are low responders. Nevertheless, in some patients who are low responders with inhibitor titer below 5 Bethesda units, factor 8 is not effective. And in those patients, we should switch to bypassing agent, either Feiba or R7A. For those patients who are high responder, whose inhibitor titer is currently very low, we theoretically may use factor 8. But please keep in mind that after use of factor 8 in this patient group, we will observe after 5-7 days anamnestic response. So the inhibitor titer increase over 5 Bethesda unit, and then efficacy of factor 8 will be low or just, will be ineffective. Therefore, for patients who are high responders and whose current inhibitor titer is low, we may use factor 8 if the patient is suffering from very severe bleed, because we believe that the first days of treatment with factor 8 may be beneficial for the patient. However, for those patients who have mild bleed, we should use still bypassing agent because we should avoid anamnestic response. In the low part of this slide, you see a remark that Feiba is associated with anamnestic response. Nevertheless, I would like to stress that anamnestic response is observed only in about 20-30% of patients treated with Feiba. Therefore, in about 80% of patients who are high responders and who receive Feiba, we do not observe anamnestic response. Therefore, Feiba, of course, can be used. And of course, even though anamnestic response is associated with Feiba. For those patients who do not respond to R7A, we still should use Feiba, because in such patients, Feiba is the only effective therapy. Okay, how should we choose bypassing agents between bypassing agents before and during ITI? So, if we are talking about patients who are awaiting ITI, so the patient will, but now we treat the bleeding problems and we try to avoid anamnestic response. Very often we start with Novo-7. If the response is inadequate with Novo-7, then of course we should switch to APcc. During ITI, of course, it is recommended to increase the dose of factor VIII during ITI to 200 units per kilo per day if the patient on a lower dose of factor VIII experiences bleeding problems. However, if the patient still suffers from bleeding, breakthrough bleeds, despite this high dose of factor VIII, 200 units per kilo per day, then we should think about prophylaxis with bypassing agent. And in the original Bonn protocol, the first ITI protocol that was developed in Germany in the city of Bonn, bypassing agents in the form of Feiba was used to eliminate or at least reduce the breakthrough bleeds during ITI. Of course, very challenging clinical situation is when the patient response to either APcc or R7A is unsatisfactory. So the patient is refractory to both bypassing agents. What we can do in such situation? First, we may increase the dose of a given bypassing agent. However, please keep in mind that APcc maximum dose per day is 200 units per kilo, so we should not exceed this limit. Then we may shorten the intervals between the doses. Sometimes if you shorten the interval of Feiba to, for instance, 6 hours, sometimes even less than 6 hours. But of course, you have to keep in mind that you cannot exceed this 200 units per kilo per day. Then you may observe better effect. Then, of course, you may change the product. I mean, if the patient responds to one bypassing unsatisfactory, then you just switch to second bypassing agent. Then you may use, in theory, sequential therapy. It is not licensed approach, clinical approach. Nevertheless, one can find in the literature some case series and case studies on sequential therapy of APcc R7A. So you infuse APcc, then R7A, again APcc and R7A. The time interval may be very different from 4 hours to 12 hours. But we should keep in mind that there is increased risk of thrombotic complications when you use. You can also use APcc and tranexamic acid. It is not officially recommended. Nevertheless, again, there are at least several case reports and case series reports on concomitant use of APcc and acid, and particularly for those patients who suffer from mucous bleeds. Such combination may be very effective, and no thrombotic complications have been described. And then, which is rather experimental therapy, APcc plus factor VIII. Even though factor VIII is eliminated by inhibitor, nevertheless, some authors describe the positive effect of such combination. This is very interesting paper. The topic of this paper was thromboembolic risk and thromboembolic complications in patients treated with bypassing agents. And generally, as you see in this table, the last column on your right-hand side, you see that the percentage of thromboembolic events was not that high. However, in the frame, I marked the patients who were treated with combined, so sequencing therapy, the other name for alternating bypassing agents therapy. So you see that for these case series, only 9 patients, nevertheless, the thromboembolic events rate was 55%, so 5 patients. So this is really high percentage, and we should keep in mind that this combination may be associated with thromboembolic events, which is not the case if you use, for instance, Feiba as a single agent. Another big challenge, patient with inhibitors undergoing surgery. It is not easy to manage those patients. However, we have to do that from time to time because of urgent surgery or even planned surgery. Of course, patients with inhibitors are really very touched by musculoskeletal problems. They have much more advanced arthropathy than patients without inhibitors. Therefore, they also require orthopedic surgery. So urgent or elective surgical procedures. So what is recommended? And again, I am showing you on this slide very elegant algorithm by Rashni Kulkarni. And you see on the left-hand side the patient who are low responders. Of course, we should use factor VIII, and we should monitor factor VIII plasma activity in those patients above a certain level, the hemostatic level, and then we may we can make sure that the patient is on the safe side. However, in patients who are high responders with high inhibitor titer, we have to reach out to bypassing agents. And Rashni Kulkarni divided those patients into 2 groups. Those who are plasma naive, never exposed to plasma products, and those who are plasma experienced, so the patients have been exposed to plasma products. And she, I would say, suggests to start with R7A in the one group and with APcc in the second group. But I'd like to stress that you can start with either R7A or APcc. However, you should have access to both bypassing agents, because in some patients we observe lack of response, not from the very beginning, but at a certain time point. And then you have to have the, plan B, yes? The switching from one bypassing agent to second can be necessary in a given case, so we should have access to both products. On the right hand side, you see on this slide, you see hemophilia B, and again, we can use either R7A or APcc, since APcc contains factor IX, and in some patients with hemophilia B, we observe allergic reactions. Therefore, in those patients with allergic reactions, with hemophilia B complicated by factor IX inhibitor, R7A may be the first choice. If R7A doesn't work, or if patients doesn't demonstrate allergic reactions, of course, you can reach out to APcc. And this is just very briefly, to show you our experience with use of Feiba with tranexamic acid in patients with inherited hemophilia A complicated by inhibitors. We published a couple of years ago in Hemophilia Journal this brief paper, and you see we showed 16 procedures, mostly dental extractions, but not only dental extractions, and this combination of APcc and tranexamic acid was really very effective. And the doses of APcc were not that low, the maximum dose was over 160 units per kilo per day, and in some patients we use for 2 weeks this combination. So as you see, it seems not only effective but also safe, what I would like to stress. Now let me show you one clinical case. This is the case from our practice, from my center. The patient, 42-year-old with severe hemophilia A complicated by high titer inhibitor. and the patient underwent total knee replacement for advanced arthropathy. We perform at least several such major surgical procedures per year in my center. On surgery day 1 and the day after surgery, day 0 and day 1, the day after surgery, the patient was treated with R7A, and this is sort of standard of care in my center. He concomitantly used tranexamic acid. On day 1, hemoglobin level was 10.2. The baseline, so the starting point before surgery, was 14. The patient received red blood cell transfusion because we were afraid that, of course, his hemoglobin level can drop down on the next day, which was the case. In fact, his hemoglobin level was 8.2 on the day 2 after surgery, and he received again red blood cell transfusion. As you see, the blood loss was over 1.5 liter during the first 3 days, or the day 0 and 2 days after surgery. No other defects of hemostasis were found, so prothrombin time, fibrinogen, platelet count within normal lab range. Surgical causes of bleeding were ruled out by surgeons. And then the question is, what would you recommend? So continue with the same regimen, increase the dose of R7A, or maybe switch to continuous infusion of R7A, or switch to Feiba. Of course, unfortunately, in the real life, I would ask this question and ask you to answer. But now I'm just giving the answer. What we did, we decided to switch to Feiba. We came to the conclusion that the patient response to R7A may be unsatisfactory, and it will be better not to increase the dose of R7A, but to switch to Feiba. And we did it. On post-op day 2, the patient received Feiba 70 units per kilo every 8 hours, so about 200 units per kilo per day. The outcome was very good. Drains were removed on day 4 after surgery. No blood in the drainage system during 24 hours preceding drains removal. However, on day 5 and 6, hemoglobin dropped again to 7.3, and the patient required again red blood cell transfusion. He reported increased pain, swelling, and sense of continuing bleeding. So the question right now, very important, critical clinical question, is, does the above meet the criteria of non-responsive bleeding? Other words, maybe the patient response to Feiba is also not satisfactory. So we thought, yes, the patient meet the criteria of non-responsive bleeding. This is the picture of the knee of this patient. As you see, of course, you can perform ultrasonography. You can try to, decide whether the patient has hematoma or not, whether the hematoma is increasing or not. But this is really not easy to evaluate only picture whether the patient response is satisfactory or not. His knee looked like that. So, of course, the best would be to measure in lab the response to bypassing agents. But unfortunately, thrombin generation assay, thromboelastometry, there are options that can be used, but the data are really discordant, and it is really hard to, to base your clinical decision on the results of those lab methods. So we decided to switch to sequential therapy in this case, and the treatment regimen was R7A 110 microgram per kilo every 12 hours, and Feiba 70 units per kilo every 12 hours. So the patient received R7A, Feiba, again R7A, Feiba, and so on. 24 hours later, the patient reported pain relief, decrease in swelling and tension. The hemoglobin level was stable over the next 5 days, and conclusion that bleeding well controlled with sequential therapy. We continued till day 14 after surgery, and then switched to Feiba for physiotherapy. So I think it can be a good reason to discuss after my talk some aspects of this case. But now let me switch to long-term prophylaxis, another important aspect of management of inherited hemophilia complicated by inhibitors. I mentioned already that in the original Born protocol, which is high dose, very intensive protocol for ITI, the patients are treated, of course, with factor 8, which is given for high responding patients, as you see, 100 units of factor 8 per kilo every 12 hours. This is very important for our German colleagues, not to give 200 units once daily, but 100 units per kilo every 12 hours. And what they did, I mean, our German colleagues in the beginning of 1980s, when this protocol was developed, they infused Feiba, 50 units per kilo twice daily, in every patient who experienced during ITI. We should keep in mind that, we should avoid bleeding, breakthrough bleeds and bleeding problems ITI and before ITI, but also during FTI. I mean, each bleeding episode matters for patient. Once complete ITI success was achieved, the dose, of course, must be tapered down to less than 50 units of factor 8 per kilo every second day as prophylaxis to maintain the immune tolerance, of course, but also to avoid accumulation of factor 8 and avoid the risk of thrombotic problems. The German colleagues shared their experience, unfortunately, in the form of abstract 20 years ago. As you see, they described 22 patients, pediatric patients, who achieved immune tolerance and who were treated with bypassing agent prophylaxis, with Feiba prophylaxis during ITI. Very good results. As you see in the lower part of this table, median annual one, very good orthopedic status after ITI, and there were no life-threatening hemorrhage, which means that bypassing agents were very effective also in eliminating this problem, additional problem, not only joint bleeds, but also other types of bleeds, like, for instance, intracranial hemorrhages. And this is a practical slide. When the sequential administration of bypassing agents, Feiba and factor 8 is avoidable during ITI, then we usually start with factor 8. Of course, factor 8 is rapidly cleared by alloantibodies, and then we infuse bypassing agents. In between infusions, of course, the venous line should be thoroughly flushed. And again, I repeat that below 5 Bethesda units and factor 8 recovery is demonstrated, we should discontinue bypassing agents to avoid the excess of thrombogenicity, avoid the at least possible thrombotic complications. So this is the practical approach to Feiba prophylaxis during ITI. Another aspect of management of our patients is long-term prophylaxis after failure of ITI. So here you can see the table from the paper published a couple of years ago by Cindy Lessinger. You see the two prospective randomized clinical trials when Feiba was used in patients with hemophilia A complicated by high titer inhibitors. The first study is Feiba study. The second one is proof study. And you see that the treatment regimen consisted in giving APcc on 3 non-consecutive days per week. In most patients, it was Monday, Wednesday, and Friday. The dose was in Feiba 85 units per kilo, plus minus 15%. And in the proof study, in the lower row, 85 units per kilo every other day, so more intensive therapy. And the results on the in the last column on the right, you see are very good. The reduction of bleeding episodes from 61 to more than 72%. And very briefly, this paper published in New England Journal of Medicine 2011, the Feiba study, 26 patients were recruited and were treated, and you see that 60 good responders. However, 10 of them were not good responders because in 10 patients, the response was unsatisfactory. In those patients on the left-hand side, you see that the reduction in number of bleeding problems was 84%. And in 5 patients, the reduction, even 6 patients, the reduction was really fantastic because the patients had 0 bleeds during prophylaxis as compared with on demand. One of my patients had 0 bleeds as compared with more than 20 bleeds during on demand. So for some patients, this treatment strategy is fantastic. For other patients, may not be adequately good. I'd like to show you 2 cases from clinical practice, 2 cases of Feiba prophylaxis. So the first patient is 36-year-old with severe hemophilia A, history of life-threatening bleeding, intracranial hemorrhage, with high titer inhibitor, with very high historical peak titer, more than 4,000 Bethesda units per milliliter. ITI never attempted in this case, also because in Poland, we couldn't, in fact, put every patient with inhibitors on ITI in 90s, in the beginning of 21st century as well, because of lack of adequate therapy in Poland. Today is much better. The patient, of course, had advanced hemophilic arthropathy. The comorbidities was hepatitis B infection and arterial hypertension. And here you see that before Prophyba study, the patient experienced 31 bleeding episodes during 6 months. So it is very severe phenotype, and 100 infusions of clotting factor concentrate. During Prophyba, he received 80 units per kilo on 3 non-consecutive days. And in the table, you see the comparison during on-demand and during prophylaxis. And you see he had 25 bleeds during on-demand, 0 during prophylaxis. So this patient was really very good patient for Feiba prophylaxis. And if you compare the consumption of APcc of Feiba during on-demand and prophylaxis, of course, the consumption was higher during prophylaxis. Nevertheless, the difference was not that high. Over 350,000 units of Feiba during on-demand and over 500,000 units of Feiba during prophylaxis. Number of injections was 55 during on-demand, 80 during prophylaxis. Of course, more during prophylaxis. Nevertheless, the efficacy of this therapy was fantastic. And case number 2, 29-year-old male with severe hemophilia A, no episodes of life-threatening hemorrhage. However, of course, advanced hemophilic arthropathy. The patient had to use wheelchair for mobility. His historical peak titer was only 51 Bethesda units per milliliter. I mean, this is, of course, high responder. Nevertheless, as compared with the first case, it is not that high. The patient attempted a very low dose ITI, but it was unsuccessful. And comorbidities, HCV, hepatitis C virus infection, the most important. And you see here, 6 months before treatment, 14 bleeding episodes, 31 infusions, and during Prophyba, the previous case, we see 25 bleeds during on-demand and 10 during prophylaxis. So we see the reduction. Nevertheless, it's not as spectacular as in the first case. So, the question may arise, was this patient a good candidate for tertiary prophylaxis? The reduction is significant, but not as spectacular as in the first case. But I can tell you that during prophylaxis, the patient didn't experience any adverse events. The patient underwent intensive kinesiotherapy, and after prophylaxis, the patient was able to ambulate with aid of one elbow crutch without need for wheelchair. Afterwards, I can tell you that the patient underwent ITI with, I would say normal dose of factor 8. And in this case, it was successful. And currently patient is on factor 8 prophylaxis, and the patient is professionally active, was unemployed. Now he has a job. So, in fact, the result of this therapy was fantastic for this patient. And this is really big success that we were able to finally eliminate inhibitor, but everything started with Feiba prophylaxis. I'd like to stress the safety profile of Feiba, because I mentioned several times thromboembolic problems, but based on this data, a huge meta-analysis that comprised 40-year the period from 1980 till 2016, 39 studies included over 750 hemophilia patients who received over 670,000 Feiba infusions. There were no thromboembolic problems in patients receiving prophylaxis with Feiba. There were some thromboembolic problems in patients receiving on-demand therapy, but it was very rare. As you see, the incidence rate was like 5 per 100,000 infusions. In congenital hemophilia, it was extremely rare, less than 0.01 per 100,000 infusions. In acquired hemophilia, of course, it was much more frequent. However, we should keep in mind A are much older, and of course, they have a lot of comorbidities that in problems. And I would like also to stress that there were no cases of thrombotic microangiopathy have been reported related to Feiba use alone. So thrombotic microangiopathy that was observed in some clinical studies published over the last couple of years, they were not observed when the patients were receiving Feiba alone. And the last chapter of my talk, APcc in acquired hemophilia A. Stress that Feiba is used not only in patients with inherited hemophilia complicated by inhibitors, but also in acquired hemophilia A, which is rare disease with the prevalence of about, or incidence about 1.5 inhabitants. So for instance, in Poland, we diagnose every year about 60 cases of acquired hemophilia A. But as you know, those patients may be treated only with, in fact, 3 drugs. And Feiba is one of them. We may use Feiba, and the efficacy of Feiba and safety profile of Feiba also for patients who developed acquired hemophilia A, the profile good. So safety, efficacy is really good for acquired hemophilia A. And this is the algorithm, how or sort of guidelines published by mostly US physicians and experts in the field of acquired hemophilia A, guidelines how we should use Feiba in patients with acquired hemophilia A. As you see, we have three hemostatic agents that can be used in patients with acquired hemophilia A. For some patients, recombinant porcine factor 8 seems to be the first option, but Feiba is still a good option, and it should be considered as a first-line therapy where, of course, this drug is available if underlying high titer inhibitor against recombinant porcine factor 8 is high, above 10 Bethesda units, and of course, if factor 8 activity measurement is not readily available, because in this case, recombinant porcine factor 8 could be the first option. So Feiba also has its place in the management of people with acquired hemophilia A. So to sum up my talk, efficacy. So with rapid onset of thrombin generation and also proven bleed resolution, Feiba is effective in people with hemophilia complicated by inhibitors to factor 8 and 9. and is approved across all clinical settings, means acute bleeding, so on-demand therapy, prophylaxis, surgery, acquired hemophilia A as well. With respect to safety aspects, proven established safety profile built over 40 years of real-world experience and minimal reporting rate of thromboembolic episodes, which is less than, as you see, 0.005%. And with respect to savings, Feiba has shown to be cost-effective treatment as compared to R7A because of more half-life and hence needs less frequent infusions, which can be also a big advantage of this therapeutic aid. I thank you very much for your attention.
Thank you, Dr. Jersey. And we have a few questions which have come up, and we would like you to explain. And we have another 15-20 minutes. And thank you for that extensive case studies which you have gone through. And I'm sure people would have understood. The audience have understood based on the real life experience you're saying. So what? So one of the questions, if I have to choose, is about the validated lab assays to monitor the efficacy of APcc. In your lab, when you are giving fiber, what test would you do to monitor the patients?
Yeah, thank you for this question. This is very relevant question. You know, in most cases, we base the dosing and the regimen on clinical picture and on clinical outcome. Only in some patients whose response is, in our opinion, unsatisfactory, or in whom we proved the correlation between lab results and clinical course, we use thrombin generation assay or thromboelastometry. I believe thrombin generation assay can be better than thromboelastometry, at least in our hands. But I'd like to stress that really data in the literature are inconsistent. I can't say that we should monitor the therapy with bypassing agents with thrombin generation or with thromboelastometry. It really depends on the local situation, on the local approach and standard of care with respect to lab monitoring. So I use from time to time lab tests, which I mentioned, thrombin generation, thromboelastometry, but in most cases, the decision the patients are treated are based, the decision is based on clinical course.
So, this question was asked by Dr. Seema Vatsa, and she has many other questions alongside. You had mentioned about one patient on whom you gave fiber and did not work. Then we switched to factor 7, did not work. And then you went ahead and did the sequential therapy, right?
Yes. Yes.
In those scenarios, what lab test did you do to monitor these patients, that particular patient?
Yes, so of course, in case of sequential therapy, we are afraid of thrombotic complications. However, there is no good marker of increased thrombogenicity in those patients. Of course, you can monitor, for instance, D-dimer. You can monitor also other markers, but you know, in patients undergoing major surgery, D-dimer levels are normally rather high.
Not, yes.
Yeah, so
Correct. So D-dimer cannot be a predictor.
Yeah.
No, did you do TGA or TEM?
Yeah, please go ahead.
Did you use TGA or TEM in those patients?
Sorry, could you repeat?
TGA, thrombin generation assay, or TEM, thromboelastometry?
Yes, in those patients, we use both methods. However, we rather use them to, avoid thrombogenicity. Other words, if such therapy works despite lot of spectacular improvement in lab test, we continue with the same regimen. However, if we observed increase in thrombin generation that can be perceived as a dangerous to the patient, I mean above the certain limit, then of course we may decide to decrease the intensivity of the therapy. So mostly the safety aspects, we monitor mostly the, we are more cautious and we are more focused on safety aspects than on efficacy. Because if the therapy is not efficacious, then of course you have to do something. And normally what you can do, you can just escalate the therapy. Because if you infuse sequentially R7A and APcc and patient is still bleeding, then in my opinion, you can do everything to stop the bleeding. So you can even add additional drugs, like for instance, tranexamic acid. Normally, you avoid such, triple therapy. But if the patient is still bleeding severely, then of course you have to do, everything to stop the bleeding. But if the patient is very good to a given therapy and you observe in thrombin generation very high levels of thrombin, then it is a signal to you, maybe you should reduce the intensivity. So this is, what I would like to say.
Sure. So Dr. Seema has another question related to this. In your experience, what is the success in ITI? You mentioned about 70% in one of the slides, but in your personal experience, what has been the real life, real world?
So very good question. So I treat only adults. As you know, most patients that are put on ITI are children. However, I talked many times with my colleagues and also, not only in my country, but also outside country. So 70% is for those patients who are able to go through the ITI. What I mean, that you start ITI and the patient accepts. In case of children, of course, you have to use central venous line access and things like that. So if you don't have additional problems, technical problems with ITI, and the patient is going smoothly through the ITI because you do not face any problems with venous access and so on, then the efficacy rate is 70%. However, some patients are simply not able to go through the whole procedure because of complications of central venous access, or just they cannot accept the intensivity of the therapy. I mean, when we talk about children, the parents must be really dedicated, and they must spend really not 5 minutes every day, but much more time to provide the child with everyday therapy, with everyday infusions, even, more than every day. It is not every 24 hours. Sometimes it is every 12 hours. This is very troublesome, bothersome. Therefore, some patients simply give up with this strategy, with ITI. So if we combine all those numbers, then probably a success rate is lower than 70%.
What is the
Apologies,
sorry, Santosh?
apologies for the, yeah, sir. These are all the questions from the various HCPs across India. So these are not from our. We just have moderated or put the questions from comments to
Okay,
rise.
okay. So I
So
don't have
these
the
are the
names.
questions. Okay, so our names are reflecting there, but we have passed on those questions from
Sure, sure,
various
sure.
healthcare professionals across India.
So, Dr. Jesse, what is the non-compliance rate in ITI in your experience, approximately? In the
Oh,
sense,
yeah. In my adult patients, we normally spend a lot of time before we start ITI in adults. I
hmm,
mentioned in my country, not every child was put on ITI because of lack of resources, 20, 30 years ago. So we have adults that have never been put on ITI, and we propose, of course, we offer them ITI. And before we start, we talk with the patients, about the, that this therapy is very demanding, that if you are successful, of course, it's really worth to go for that. But it's very demanding because you have to infuse every day. Maybe it can last for years even, not only for months. So some patients give up at the very beginning of our talk, that they simply cannot accept everyday infusions for months because they didn't used to infuse every day. They are not on prophylaxis. They prefer.
What is that approximate? What is that number approximately? 10%, 20%, 50%
Oh, I
of
would
them
say,
will drop out.
oh yes, I would say at least 20%. At
Will
least
drop
20%.
out.
They don't accept such intensive therapy. And then, non-adherence, I would say after such preparation to ITI, I would say this is about 10% of non-adherence. So we have,
10%.
yeah, so, yeah.
So 90% are really on board with that. Okay. So
Yeah.
there is an interesting question from Kerala. Kerala is in southern part of India, to
Yeah.
make you get that entire thing in. HTC Alva has one hemophilia child with inhibitors against factor 7, which was diagnosed in Velar. How to manage a child when he gets joint bleeds now? And hits a factor 7 with joint bleeds and inhibitors. And dental extractions were managed with tranexamic acid, but we need to know about how to do the long-term management inhibitor in factor 7.
Oh, this is very difficult question because I have to say that we have relatively, I would say, when we compare population of Poland and India, of course, we can't compare. But nevertheless, we have relatively big population of patients with factor 7 deficiency in Poland. This is more than 300. And I have, every week or maybe every month, I see patients with severe factor 7 deficiency, but have never seen patient with inhibitor to factor 7. Never. We have very severe factor 7 deficiency, less than 1% of activity. We normally treat such patient with R7A or with plasma-derived factor 7. We try to avoid use of PCC, prothrombin complex concentrate, because we believe that particularly if we talk about intensive therapy, the patient may be at risk of thrombotic complications because, of course, PCC contains, besides factor 7, also 9, 10, and 2, which is within normal range in patients with factor 7 deficiency. So in such a case, the honest answer is, I don't know. Maybe I would try R7A because R7A, in my opinion, could be effective despite inhibitor to factor 7. I wouldn't use plasma-derived factor 7 because, of course, because of an
Neutralize.
Yeah, I've never encountered article paper on ITI in patients with factor 7 deficiency complicated by inhibitor. So I'm sorry, but I can't add anything to that.
So
So,
you
Dr.
don't
Joseph,
even,
sir, what's
sorry.
your opinion? Dr. Joseph, sir, your opinion on this particular question?
Okay, so it's a
Your
tough
thoughts,
one,
your
I must
opinion.
say. I would
Okay.
say I would try and avoid as many exposures as possible, but I would not want to try an ITI here. I would be inclined, if there is excessive bleed and it is not stopping, Feiba may be a reasonable choice. I would take the risk of thrombosis and give it if there is excessive bleed. What else can you do? So, Dr. Jesse, where do you place bypassing agents in the era of non-factor therapy possibilities available? Where do you foresee the role of Feiba with emicizumab and fitusiran coming on board now?
Yeah, of course. I expected such question. Definitely, we should keep in mind that emicizumab, fitusiran, and other non-replacement therapies or non-factor replacement therapies are only for prophylaxis, only for long-term prophylaxis. They are not for treatment of
Controlling
bleeding
acute.
episodes. And so you can't treat your patients exclusively with emicizumab, fitusiran, and other, drugs that are in the pipeline. We have to have access to bypassing agents because if we talk about breakthrough bleeds, surgery, injury, and of course, lack of response to novel therapies. Because please keep in mind, in Heaven 1, we had at least, I don't remember the exact number, I think 8 patients many patients had bleeds. Most of them, very few. Some of them had 0 bleeds, but some of them had many bleeds being on Hemlibra in Heaven 1. So we should keep in mind that in those patients, we need to have plan B. Bypassing agents are definitely plan B for those patients. And we should also keep in mind that Feiba and PROOF demonstrated efficacy of Feiba in long-term prophylaxis. And for some patients, I believe it can be really the best option. Of course, from patient perspective, subcutaneous injections are much more tempting than intravenous infusions. But from a perspective of efficacy of therapy, for some patients, Feiba can be better than emicizumab. So definitely there is still a role for bypassing agents, and in the future we need to have access to bypassing agents, definitely.
Sorry, I lost the
Okay, Jay.
connectivity for a while, for a few seconds. Am I
Sure, I
audible?
will. Yeah, you are
Dr.
audible,
Santosh?
but not with. Yeah, you are audible, sir. You can go ahead, please. You are audible. Or I shall put up the question: what are the special precautions for vaccination in children with hemophilia with or without inhibitors? Means in terms
Oh,
of immunization for patients with hemophilia. So, what should be the special precautions, if any, that needs to be taken for these children?
Oh, that is very good questions. In a couple of years ago, it was believed that vaccination should be performed without any injection of factor because such combination can increase the risk of inhibitor. But this is not true anymore. So you can infuse clotting factor and perform vaccination, and definitely we have evidence that there is no increased risk of inhibitor. It's been also, mentioned in the current guidelines by
I,
WHO.
yeah, I hope I was about to tell the same. The same
Yeah,
thing has been well illustrated in the 9.4.3 recommendations, clearly about going for the vaccinations for the children and no need to stop any vaccination, and if possible, use intradermal or subcutaneous per se in that case. So the next
yeah.
question is, could you kindly explain the mode of action of APcc and also the time taken to start the action?
Okay, that's good question. So I mentioned in my presentation that probably the most important, the key elements are factor 2 and factor 10. Doesn't matter, activated, non-activated, but those two. But we know from the last years that it is not only factor 2 and factor 10, that the whole combination really plays role. People from Takida, Vienna, Dr. Turecek, Peter Turecek, before Dr. Varadi, they publish very nice papers on that. Of course, this is pretty complex, stuff, but I don't want to go into details. But this is the unique properties of Feiba. This is of all proteins. Also, there is TFPI also in Feiba, which also plays positive role, even though it is inhibitor of coagulation. So, those who are interested, I would refer to the to the literature, because this is pretty complex topic.
Thank you, sir. The next part regarding the onset of action, the time taken for the onset of action of APCC
Or
was the next.
yeah, yes, we believe this is really immediate. I mean, I mean immediate means within half an hour or something like that. Just infuse, and you should expect the efficacy, the action of fiber.
So, Joseph, sir, you can take from one patient need to undergo surgery. Sorry,
Hmm.
I pitched in your space of challenge with internet connectivity. So, we were
Yeah,
here
yeah.
in one patient need to undergo surgery. You can take from here, please.
Yeah. So there's one question which is there. It's an interesting question. So what would be the choice of therapy in a high titer inhibitor, and he has to undergo an amputation?
Yes, so we in our center we very often start with R7A, and then we switch to APcc. And this is because, among others, because of half-lives. We believe that in the first days, on the day of surgery, first days after surgery, the very frequent intravenous infusions is not a drawback of R7A, because the patient requires very close monitoring, nurses are involved, you know what I mean. But after a couple of days, we prefer to switch to Feiba because we believe that it is much more convenient for the old staff. It depends. It's good, of course, to switch to Feiba because of longer half-life. But we should have access to both bypassing agents. I will repeat again. If the patient response is unsatisfactory to the first agent, we have to switch to the second one. This is definitely what I recommend, to have access to both bypassing agents.
Sure. Some basic question. How do you explain to the audience how you classify patients into a high responder and a low responder?
Sure. So we stick to the definitions given by official organizations. So low responders are those patients in whom inhibitor titer is below 5 Bethesda units. 5 Bethesda units. So it can be 1 Bethesda unit, but it can be 4 Bethesda units. It doesn't mean that response to factor VIII will be the same in both patients. What I want to stress. Nevertheless,
That's a low titer.
yes, I mean, because patients can be low responder, nevertheless may require therapy with bypassing agents because his response to factor VIII is not satisfactory, even with very high doses. Patient who is high responder is the patient in whom inhibitor titer may exceed, or maybe at least 5 or over 5 Bethesda units per milliliter. Other words, if the patient is exposed to factor VIII, we should expect anamnestic response, and the patient inhibitor titer increases over 5 Bethesda units. However, if the patient is not exposed to factor VIII, then inhibitor may decrease even to undetectable level. So if you just measure inhibitor in high responder by chance, you don't know when he was exposed to factor VIII, then of course the results can be zero. Therefore, it is extremely important to record all test
So it's
results.
a retrospective way of analyzing a response. Yeah. Okay.
Absolutely, absolutely.
Okay. If there is an inhibitor patient on imizumab and needs a surgery, how to go about the sequential therapy with R factor 7, I mean A, and Feiba if required. As Feiba is contraindicated hemistocimab, just like the case one discussed. Suppose he was on hemistocimab previously. Is this a probable serious handicap onto using hemistocimab? In other words, in hemistocimab, when you have to use, how do you place Feiba and recombinant factor 7?
Yes. So thank you for this question also, of course. The number one in patients on EMI is R7A. Definitely. This is the first line therapy. If we have to use bypassing agents in patients on EMI, number one is R7A. But I have to add that we should monitor inhibitor titer in patients on EMI, because patients not exposed to factor VIII, of course, will eliminate inhibitor. Nevertheless, if we infuse factor VIII, of course, the anamnestic response will occur. So in patients on EMI who requires surgery, we first have to measure inhibitor titer. If the patient's inhibitor titer is very low, we can perform surgery with factor VIII, and once anamnestic occur, we switch to bypassing agents, and the first choice is R7A. Very difficult situation is if the patient response to factor R7A is unsatisfactory. Then the only option you have is APcc, is Feiba. And in such case, you have to start with very low dose. In SPC, it is recommended 50 units per kilo. However, there are some reports in the literature that even as low doses as 15 units per kilo may be efficacious. And for those patients, probably monitoring of thrombin generation is helpful. I mean, I know at least several reports, and also we performed such strategy, and we observed with low dose Feiba, we observed in patients on EMI increase in thrombin generation that was satisfactory. So this is pretty complex. In some patients, if we are afraid of patient on EMI, if we are afraid of his response to R7A, and the patient must undergo surgery, requires surgery, and you can wait a couple of months until EMI, after stopping EMI, discontinuation of EMI, the EMI will be eliminated from the body, because please keep in mind, EMI, after you stop EMI, EMI remains in the body for a couple of months. So if you can wait, then I would recommend to wait, to perform surgery, and go back to EMI. Yeah, this is also an option. So because I will never, I mean, I'm very respectful to thrombotic problems and thrombotic microangiopathy described in heaven and also outside clinical trials. We have to be very cautious about those problems in patients on EMI.
So, Dr. Santosh, is it time to summarize, or we have more time?
So there are just one question is there last, I think, regarding the CNS bleed. I think with that we can conclude.
CNS bleeding.
Can you just read it out, because I'm not able to see it?
Sure. So yeah, I will just read it out. Which of the bypassing agent is preferred in hemophilia A patient with acute CNS bleed? And what is the endpoint of deciding the duration of APcc or recombinant factor 7 to switching to factor 8 prophylaxis in this patient in whom the CNS bleed has been managed?
Okay.
It's basically asking about how to approach the case with a CNS bleed in a patient with an inhibitor, basically hemophilia patient with inhibitor.
Yeah, so both bypassing agents, of course, are allowed. There are several algorithms published in the literature, and definitely the most important is what we know about the patient. If the patient response to Feiba is better than to Novo7, in some patients we can say that. Then, of course, you should start with better bypassing agents for this individual. If Novo7 is better, then you should start with Novo7. Of course, the most difficult part of this clinical scenario is how to monitor the efficacy of the therapy. And you have to base your therapy on imaging studies, definitely. And of course, clinical course. Because again, lab is not enough. I mean, thrombin generation assay, thromboelastometry, what I said before, I don't want to repeat. You can't rely on test. So imaging studies and of course clinical course, absolutely collaboration with neurologists and so on. Yes, I mean, for how long? I would say that at least for 2 weeks or maybe even longer. This is very difficult, maybe for 2 weeks, full intensity of therapy, then a little bit lower intensity. There are many aspects of this situation. Costs are huge. So for such therapy, so we also have to keep in mind that we should remember about that. But of course, the patient is the priority.
So thank you, Dr. Jesse, for your wonderful
Thank you.
description of your experience and sharing your experience with Feiba and the other medications in patients with inhibitors. As I said, inhibitor is an area where many of the centers across the country are slowly gaining experience, and many people are finding their way because it is only now we can even talk about the availability of Feiba or factor 7A, and emicizumab has also come round the corner. So a lot of education is required among the healthcare professionals here who are managing this. And today we discussed about managing patients on various aspects, choice of bypassing agents. We talked about bleeding, we talked about prophylaxis, and we touched upon ITI, not in elaborate manner, but that is one area we need to explore in the country, the treatment. And we talked about surgery as well. Thank you so much. And thank you, Takeda, for organizing this meeting here so that we could reach out to many healthcare professionals who are interested in the area of inhibitor management. Over to Dr. Sandhu.
Yeah, thank you, sir. So I would like to thank the speakers, Dr. Jersey and Dr. Joseph, for a fascinating and intriguing scientific discussion. I hope it was a great learning for all the treaters of hemophilia across the country, and the specific scientific session would help in improving the diagnosis and ensure an optimal management of hemophilia patients with inhibitors. And also, this would enable and improve their health-related quality of life for patients with hemophilia. I express my gratitude and thanks to all the participants who spared their valuable time for attending this session. And let's all stand united for hemophilia. And once again, but not the end, but would like to thank the both of the speakers, Dr. Jesse and Dr. Joseph, for their valuable time in sharing their experiences about managing the patients with hemophilia with inhibitors. Thank you, sir.
Thank you.
Very much. Thank you.
Thank
Good
you.
luck.
Bye bye. Have a great evening.